very distinguished scientist, HIV practitioner, mover of policy in a very incredible and worldwide way. I could sing his accolades all day long, but one of the ones that I picked out was in 2012, he was named by Time magazine as one of the 100 most influential people in the world. As you hear his lecture, you will understand why. I knew Bob when? I knew him, he was a postdoc, and I was his mentor. I mean, one doesn't offer mentoring advice to a person such as Bob. You say, just follow your passion. And indeed he has. And one of his main areas has been in the area of pre-exposure prophylaxis, and he's now very heavily involved in the city of San Francisco's effort, considerable effort, to reduce HIV transmissions to zero, new HIV infections down to zero. He's currently a research investigator at the Gladstone Institute at UCSF. He's a professor of medicine at University of California, San Francisco. He's the chief medical officer for the San Francisco AIDS Foundation, and he's a major consultant to the World Health Organization in its HIV prevention and strategy and policy. And I follow him on Facebook, and he is bicycling madly around the city of San Francisco to train for the San Francisco to LA AIDS bike-a-thon, bicycle ride. So he's an all-around great guy, and we're just glad to have you here. So thank you.
Thank you, Tom, and thank you to all of you for coming out and hearing the story about scaling up PrEP to impact HIV transmission. But before I leave Tom Coates, you know, I have always appreciated Tom's mentorship. He's given me wise and sage advice, and unlike many mentors, it isn't always selfish on his part. I mean, he really tries to think through what is best for me. But now I realize that I should be frightened. He's like a parent who has baby stories that he can tell about me. And I'm glad that you showed some restraint there, Tom. I always start with disclosures. Gilead Sciences, who makes emtricitabine, tenofovir disoproxil fumarate, donated study drug to the US NIH for studies that I had the opportunity to lead, including the IPREX study, the IPREX open label extension, and HPTN 067. In addition, ViiV, another pharmaceutical company, contracted with my employer Gladstone to support a phase 2 research study of long-acting injectable PrEP. That second agent is not FDA approved. The phase 2 studies were presented, and I'll be discussing them briefly in this talk. I do not personally take money from Gilead. In some ways, it's a shame I don't. I'd be rich otherwise. As an outline for my talk, discuss briefly PrEP evidence and recommendations, and then describe how a tipping point in PrEP demand has been reached in the United States, try to speculate some about why that occurred and how that occurred, and describe emerging evidence that PrEP is having an impact on the rate of HIV transmission, but to really highlight that there are disparities already in PrEP access and use, and particularly related to young people, young adults and adolescents, and how at least one organization has provided wraparound services for youth that seems to be helping. I will touch on long-acting injectables and the possibility for strategic dosing of PrEP or non-daily strategic dosing. So I am optimistic about the HIV epidemic, and I think that there are several recent advances that allow us to imagine ending HIV transmission. Key among them, I believe, is marriage equality. Full citizenship for LGBT people really does change the discussion and perceptions in a way that allows people to focus on health risks. Healthcare reform provides unprecedented access to our healthcare system. Rapid HIV tests make it easy to know whether infections occurred. HIV therapy, as you all know, has triple benefits, prolongs life, decreases transmission, and prevents opportunistic infections that are themselves transmissible, like tuberculosis. PrEP, I think, is among them. Certainly not the only one among them, but I think it's a key part of what allows us to imagine ending HIV transmission. But finally, I think it's social media. Social media is allowing peers and PrEP users to share information in unprecedentedly candid ways. And there are barriers, though, and I think that how we address these barriers will ultimately decide whether we end this epidemic now or we wait another several decades to do it. We all work in fractured communities, and this, I think, is highlighted in this pioneering book by Mindy Fullilove called Urban Alchemy, and she talks about ways to restore joy in America's sorted out cities. I think health inequality, public health silos, I think, have been helpful in allowing focus, but let's face it, our epidemics are all linked with one with another. HIV, HCV, reproductive health, vaccinations, sexual health, TB, violence, trauma, addiction, all of these health phenomena, all of these epidemiologies are in fact very much related to each other, and breaking out of the silos is a key part of our ultimate success. An underinvestment in social capital, and also the notion that we're always waiting for, and this is, I think, something that affects us in academics. You know, we're waiting for the next, the better PrEP agent, or the better test, or the better this or that, and it's fun to think about innovations, but we can also learn and benefit from applying what we know, and there is a role for academics in implementation science at all phases of the implementation cascade. I was happy that the WHO in September 2015 has finally issued a broad and strong recommendation for PrEP, and I think the wording is important. They said oral PrEP containing tenofovir disoproxil fumarate should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination prevention approaches. And this was a strong recommendation based on high quality evidence after a systematic grade analysis. And the grade analysis goes far beyond what our normative agencies in the US normally do, because it considers data about safety and effectiveness, as everyone does, but it also considers information about feasibility, acceptability, cost effectiveness, and ethics. And this review is now published in AIDS just last month. I think it's key that they're not specifying only FTC TDF. They're saying regimens containing TDF, and they're saying it should be offered, not recommended. It's, the goal here is to engage people in decision making. And then finally, it's an additional choice to be combined. And they've also moved away from what are called key populations. This is not a recommendation just for gay men or for transgender women or for people who inject drugs. This is for anyone who's at substantial risk, which includes people in those key populations, but not everyone in those key populations. And it includes people who don't have any of those identities for whatever reason. So I think this is really an enabling recommendation that has had an impact globally since of course, since 2012, the FDA had approved Truvada for PrEP in the United States. Truvada is the co-formulation, the branded co-formulation of emtricitabine and tenofovir disoproxil fumarate. The CDC issued broad recommendations for PrEP in the middle of 2014, and it's been picked up by a variety of states, including California and New York. But since the WHO recommendation, we've seen approvals for PrEP in South Africa, France, Kenya, Canada, and Israel, and 2 other countries have approved PrEP but don't yet have public health programs for providing it, namely Peru and Switzerland. And this is in addition to about 40 different countries around the world that are sponsoring demonstration projects that provide PrEP on a more limited scale. These are just the countries that have made nationwide commitments to make PrEP available. But it's only in the United States where we've seen that demand has reached a tipping point for PrEP. And the question for many years after we published our IPREX results in 2010 was, why do I think that anyone wants PrEP? We went from 2010 until late 2013 before we saw any real substantial demand for PrEP, a good solid 3 years. And this is data from Gilead Sciences through their FDA-mandated surveillance program of pharmacy dispensations of PrEP. And you can see that really throughout 2012 and early 2013, demand for PrEP was flat. The number of people starting PrEP nationwide in this pharmacy survey was under 500. And it was really a tipping point was reached in late 2013, early 2014, and has been growing exponentially ever since. PrEP use in the United States is now doubling, we think, every year since 2013. And what is it that caused this tipping point? Well, I highly recommend Gladwell's book called The Tipping Point. And one of the things he'll say, though, is that when demand hits a tipping point, you don't always know what exactly happened. It often happens when pioneers interact with early adopters, and you don't necessarily know exactly why it hits a tipping point. But in the case of PrEP, I think we have some ideas. One was, starting in late 2013, we started seeing PrEP combined with positive messages. It used to be that PrEP and all other HIV prevention was cast as a way to prevent you from getting HIV, which is not something that people want to even think about. So we want to prevent you from getting something that you were hoping not to even think about at all. And that, in the end, was not a very selling message, at least not for broad sectors of the population. But people came to realize early on that PrEP could be framed in a positive way. And so this is some work done by the San Francisco AIDS Foundation saying that love may have another protector. And keep it real with PrEP, and preservar la pasión, preserve the passion, an additional layer of love. So this was one of the first times that we saw, well, that's not true. Tom's in the room, so I don't get to lie about that. But it was, one of the times where we saw successful framing of prevention messages in positive frameworks. And I caught myself because I realized that some of the pioneering work that Tom and his colleagues did in San Francisco in the 80s was related to condom promotion in a positive way. And, you know, let's face it, the billboards, very good-looking men saying, "Be a rubber man," were effective. They did inspire condom use in the 80s, partly because it was a positive message. Condoms at that time could be sexy because it was an alternative to staying home and just worrying about HIV. But these were positive messages framing PrEP. And we think it worked. This is hits on the website when the positive messages came out, and we can see a tipping point in demand for information about PrEP in the third quarter of 2013. But I think that this is no longer the state of the art. What I showed you were cartoons, pretend people talking about positive aspects of PrEP. This, I think, is the most inventive campaign that I've seen this year, coming out of Jim Pickett's work at the AIDS Foundation Chicago, where he's now photographing real people, and he's combining classic terminology in epidemiology and prevention, words like catch and contract and spread and transmit, but he's now combining them with sexy words and words that are consistent with people's social and sexual and reproductive goals, things like desire and heat and tingle and love. And this is, I think, the state of the art. Real people, not cartoon people, but real people who are desiring social interaction and sexual interaction, and they want it a certain way, and they don't want HIV. And this is the perplexity that we live in, and this is what's captured in this campaign, framing PrEP in a positive way to resolve the dilemma about fear of HIV. But I think that ultimately what caused us to hit a tipping point is that PrEP users came out and said, wait guys, I'm not a Truvada whore, I'm actually proud to be on PrEP because that is the way that I protect myself, it's the way I protect my lovers, it's the way I protect my community. And the guy that I think pioneered this in the United States is Damon Jacobs, but there were some PrEP users in LA who came out early on. But Damon Jacobs came out in November 2012 and said on Huffington Post Live that he was proud to be a PrEP user and why. And that was the game changer. And I remember this very well because I was also in the interview, although not quoted as much as he because I'm just not that good looking. But, but I also remember because for more than 2 years, the press had been calling me and say, Dr. Grant, we want to talk to a PrEP user. And I could not find them, a PrEP user who'd be willing to talk to the press with their own name. Until of course now it's easy for the press to find PrEP users, but it wasn't in November 2012. But there are others too. Batambili, a sex worker in Zimbabwe, said PrEP empowers me because for the first time ever, she has control over her risk of HIV. She doesn't have to count on her clients to use a condom or to tell the truth about their HIV status. She can control her risk, so she says it empowers her. Najee Dawkins, a young man in Oakland, also a PrEP champion, and then Scott Wiener, elected official, who came out and said, coming out of the PrEP closet. All of this made a difference. Overnight, these few heroes changed the discussion from stigmatizing PrEP Truvada whore to Truvada heroes. It makes a difference in demand. Now, I wanted to focus a bit on San Francisco because I love the city. I'm from there. I get to spend some time there, not as much as I'd like. But I do think that the city of love could lead the way toward ending HIV transmission. And I think that part of that is the dissemination of PrEP innovations, which I think we can track along a classic marketing framework of dissemination of innovations, which classically goes from innovators to early adopters to early majority to late majority to laggards. And what I think that we need to learn from this tried and true theory is that each one of these layers have different information needs, they have different trusted information sources, they have different ways of looking at the world. And I can see this in my PrEP clinical practice at UCSF. The innovators, and for sure, we are in San Francisco stepping up this dissemination pathway. My colleague at the DPH, Albert Liu in San Francisco, documented that PrEP was passing from innovators to early adopters by the late 2013. I showed that by the end of 2014, early adopters had pretty much picked up PrEP and were starting to pass it off to the early majority. And then Stephanie Cohen, just a few months ago, presented in Atlanta information that 20 to 30% of gay men in San Francisco at the end of 2015 were using PrEP. And so we see us progressing along this dissemination of innovation. Now, each one of these groups has different information needs. They have different questions they ask. The innovators, particularly, are people like participants in clinical trials. And what they seem to care about, what they asked us, is PrEP important, and is it really new? Or is it just the same old, same old? And we were able to say, if it works, PrEP could change the epidemic. They liked that. They were able to participate in our trials. It took a while for them to get to that point. Early adopters are very different from innovators. They want to know, more than anything, does PrEP work well? And I think this is a question that early adopters are known to ask, whether they're adopting a new iPhone technology or something else. They really want that new thing to work well. And they get really angry if it doesn't work. If one little feature on the phone doesn't work, God, they're upset in arms and they blog all over. PrEP early adopters were exactly the same way. And all of this discussion about how well PrEP works, which was, some people said it was 44% effective, others said it was up to 90% effective, others said it was more than 90% effective, or is it 99% effective, or is it really 100% effective, and there's a public health conspiracy to try to keep us from knowing that. All of that discussion is a quintessential early adopter discussion. What they care about more than anything else is how well it works. And in the end, being able to say quite truthfully and in an evidence-based way that PrEP works when used is the key message for them. But the early majority had a different message. They want to know who's using PrEP. And I remember this in my clinic, because for the first year of providing PrEP, this is, it was all about how well does it work, does it really work well? And then suddenly in 2015, I started seeing people who come in who'd say, well, I want PrEP because everyone I meet online is already on it, and I want to join them and be part of their club. And that is an early adopter discourse. Who uses PrEP? And I think we can say that responsible and attractive people use PrEP when they can benefit from it. We haven't yet seen the late majority in the PrEP field, but they are there very much in the treatment field. And so we know the kinds of questions they ask. How easy can PrEP be? You can also say how easy can treatment be? This is what the late majority wants. And I think this is our current challenge. Can we design PrEP services that are easy so that the late majority will step up and do it? And then the laggards are always difficult to get to. They're going to say, do I really have to use PrEP? Just as they say now, do I really have to take HIV treatment? And I think that we can say you don't have to get HIV, but it's not just me. Let's listen to Honey LeBronc's.
That just found out he's HIV positive, he's never heard about He never heard about it. And of course, when I told him about it, he said, if someone had told me that this was an option, I would be taking it. I would have taken it already. Too late for him. Now he has HIV, and he will for the rest of his life. So you don't want HIV? You don't have to get HIV. You don't have to get HIV. Get PrEP.
So, you don't have to get HIV. Amazingly, now you don't need a professor of medicine from San Francisco to come down and tell you you don't have to get HIV, but at the heart of it, this is the pivotal message. You don't have to get HIV. We have so many different ways to prevent HIV, to protect oneself from HIV, and PrEP is just one, which I'm here to talk about, but there are all these others. You don't have to get HIV. PrEP provision is happening throughout California. This is a now California state-funded program, a website called pleaseprepme.org. It lists PrEP providers throughout the state, and you can see that LA, San Diego, and San Francisco have an abundance of PrEP providers. It's a little more sparse outside of the urban areas, but that's okay. Most of the transmission is occurring in these three areas. And in San Francisco, it's a diversity of, we used to debate who should provide PrEP. And in the end, we realized that everyone should provide PrEP. It's really part of primary care. It's part of sexual health care. And if your patient is non-sexual, then you don't have to worry about it. But most of us have patients who are sexual in some respect. And so we think that all of the above should provide PrEP. HIV/AIDS specialty clinics, sexual health clinics, student health services, and general practitioners. And for sure, all of them are stepping up to get the job done. The biggest PrEP practices are appearing in sexual health clinics because it's an easy fit in that setting. HIV testing and STI testing is already occurring. Wanted to highlight our work at the San Francisco AIDS Foundation, where their magnet clinic, now called Strut, is a community-based organization which is funded by government contracts. And their first PrEP client visited in November 2014, and more than 800 were started on PrEP in the following year. About 10% of gay men in San Francisco receiving PrEP are receiving it from this clinic. It's directed and staffed by nurse practitioners. There is a doctor on call, and I'm a second layer of call, but we're not called very much. It is really run by nurses. They use point-of-care creatinine and HIV antibody testing. If there's any question about acute infection or recent exposure, they start a 3-drug PEP regimen and transition it seamlessly to PrEP. We start either PEP or PrEP on the same day that the person walks through the door, because there's something that motivated them to walk through the door. And we may or may not hear about that in our sexual history, but we can see that the incidence of HIV among people requesting PrEP is enormous. It runs typically 3 to 4 times what you would expect following cohorts. And it's a racially and ethnically diverse program. There's no charge to the patient. We do write prescriptions, and we have a staff of navigators who helps those prescriptions get filled, either through the Gilead patient assistance programs, through Medi-Cal, or through private insurance. And we're able to get more than 95% of the prescriptions we write can be filled, although sometimes there's quite a lot of paperwork. So we do have this cadre of navigators who help with that. But we are not making it the easiest. There's a pharmacy in Seattle, Washington that has opened a program called One Step PrEP. Again, it's same-day starting of PrEP. This is a pharmacist-run PrEP service. They have a medical clinic two floors above, but basically the pharmacists are doing a great job doing the HIV testing, checking the creatinine, and getting PrEP out to people who need it. So pharmacies can get into this. And then even online pharmacies. I'm pro bono consultant for Nurex. It's an online PrEP provider. They started in contraception because women were having a hard time getting their birth control refilled. And they made that easy in California and New York, and now they've extended it to PrEP. And they essentially go online, you give your sexual history, you interact some with the provider, and then go to the lab, local lab, Quest or LabCorp currently, and then if the labs look good and you still want PrEP, and your questions are answered, which can be done online or through text or telephone calls, then PrEP is delivered to your door. And that's currently working in California and will be starting in New York relatively soon. This is the easiest way that I know of to get PrEP.
Bob,
Yeah.
That's online, so it'll be available here in LA as well.
It is available in LA.
And
Yeah.
they will deliver it like UPS? Or
I believe so. No, they have couriers.
Couriers.
It'll probably come in a bike. But is it going to have an impact? I think we probably have seen the data reviewed by the WHO that PrEP works when used, but if you let it loose in ecological systems like cities of LA and San Francisco, is its net impact going to be favorable or disfavorable? And that is, I think, has been an open question, something that we've explored in San Francisco with my colleagues at UCSF and the Department of Public Health. That clock hasn't moved. Is that the time? Okay.
Yeah, it's 12:30.
All right, great. One thing we discovered looking at 3 different ways of looking at PrEP utilization. One was a walk-up survey done by Stop AIDS. Another was a probability sample, a proper epidemiological study, if you will, called the National Health and Behavior Survey in San Francisco alone. And the other was a convenience sample among STD clinic visitors done at what we call our city clinic, but it's a municipal STD clinic. And what was remarkable is the concordance, despite the very different sampling frames and very different costs associated with each of these 3 studies, they pretty much show the same thing, which is that 10 to 15% of gay men were using PrEP by the end of 2014. And that PrEP was being particularly taken up by, or preferentially taken up by people who had the most to benefit from PrEP. If you look at the strata of men who reported 6 or more condomless anal intercourse partners, PrEP uptake by the end of 2014 was already 50 to 60% among that strata of men. And then among those with 0 condomless anal intercourse partners, PrEP uptake is not as high, but it is, we think, appropriate even in a large proportion of that group because of a recent diagnosis of STI or something else. So this is one of the lessons that I want you to take home, which is that PrEP demand is here. It had arrived in San Francisco at the end of by the end of 2014. And 2, that at least among gay men, we're seeing PrEP taken up by the people who will benefit the most from it. One of the concerns that we've heard in the past is that only the worried well will go to the trouble of getting PrEP. Not so. We do not see this in San Francisco. We don't see it in the demonstration projects. It's really not been the norm. Perhaps fortunately, this particular medication is not, doesn't have favorable psychoactive properties. It doesn't make you high. There's no reason to take it unless you're really anxious about HIV. And the majority of people who are anxious about HIV will benefit from PrEP because it makes them feel safer, because it actually makes them safer. And so this is a favorable characteristics of the product that at least we've been able to see so far. And this also leverages the impact, which I'll get to. But how many people in San Francisco, and this is the scary slide, but it's kind of hidden how scary it is. But this is one estimation, basically my estimation with my colleagues, about how many people would be eligible for PrEP in San Francisco, and we get to a number of 16,000. The majority are men who have sex with men who have 2 or more partners. Some of them have fewer partners, but they have an STI diagnosed. There's certainly female partners of HIV positive MSM, some of whom know that they're in that relationship, others don't. Trans women can be at risk, but we think there's 16,000 who could benefit from PrEP. Now, that number, you wouldn't know unless you knew how small San Francisco is, but that number of 16,000 is roughly the same number of the people living with HIV in our city. So this implies that those eligible for PrEP may be as numerous as the people who are eligible for HIV treatment. And now that was a bold projection, but in December of 2015, the CDC issued their estimations of nationwide eligibility for PrEP, and they come to 1.2 million people are eligible for PrEP based on CDC criteria, also a number which is roughly equivalent to the number of people living with HIV, or at least the old estimate of that number. So there are a lot of people who can benefit from PrEP, is the point I'm making. Now, what kind of impact might we expect? We developed really an Excel spreadsheet model which wasn't like most of the models that you've seen, which try to predict the effect of an intervention 10 years from now or 20 years from now. We were more modest. We said, let's try to predict what our case rate's going to be next year, 12 months from now. It almost feels like cheating, but it did allow us to make our model simpler and more detailed because we had surveillance data on a number of different behavioral practices and PrEP uptake. And this is what we were able to estimate, is that with increasing PrEP use, measured now as person years of PrEP use, we would see a decline in the number of new infections, and this is all comers, not just MSM. And this is assuming that treatment rollout would stay about what it has been. And did it predict? Oops. Well, PrEP use was negligible in 2011. We know that from the NHBS survey. And we had 420 new cases there. That's not a finding. That's, in fact, how we calibrated the model. We predicted that in the end of 2014 that there would be something like 310 new cases of HIV. And sure enough, there was 302. So the model tracked pretty well with the number of new cases. Like I said, we now know that PrEP use doubled again in 2015, so we're predicting something like between 200 and 250 new cases of HIV, and we will see in August whether that prediction comes true. But this is the time trends of HIV cases in San Francisco, and you can see that we've been early adopters of routine testing, HIV RNA testing, for acute infection at baseline, antiretroviral therapy offered at diagnosis, and now PrEP. And you can see that we've seen overall a decline in new cases. It did stabilize between 2009 and 2012, but really there's been a 29% decrease in new cases since between 2012 and 2014 during the PrEP rollout. I do think that there's encouraging data coming out this year, but I can't talk about that yet. Now, this is obviously a complicated system, and treatment certainly played a role in decreasing the number of new infections, but our success in testing and treatment in San Francisco is staying about the same. Despite Herculean efforts. And you can see here the last two bars. This is our Cascade. The last two bars are viral suppression rates among all people living with HIV have stayed in the high 60% range for those 2 years, over which time PrEP was exploding and HIV cases were plummeting. So I do think that PrEP played a role in epidemic control in San Francisco and is continuing to play a role. But these are not competing interventions. I think that we can see also that PrEP is enabling treatment rollout. Like I said, treatment rollout's in a very different stage of the dissemination of innovation. They're up against the late adopters, the late majority, and the laggards, people who need a different discourse. And so PrEP is reinvigorating that discussion in several ways. One is there's less HIV infection, but also people can see in their social networks that these ARVs are safe. This notion that antiretroviral medications are poisonous and you should avoid them if you can, even if you're HIV infected, is dismissed or dismissible when you have a friend who is taking PrEP who's not HIV positive, and HIV negative. And an anecdote I will tell is actually a young woman in her early 20s presented to a PrEP clinic in Chicago and said that her boyfriend about the same age is living with HIV, but he refuses to take therapy because he's afraid of the stigma and he's afraid that the drugs are going to make him sick. And yet she wanted to stay in this relationship, and they weren't using condoms because she would actually be okay if she ended up pregnant. And she loved him so much. And so she said, but I don't want HIV. And so I'm going to start PrEP. And she went home with her PrEP bottle, and 2 months later her boyfriend shows up and says, I want therapy. You know, I thought the drugs were poisonous, and I didn't know that I was brave enough to start therapy, but my girlfriend did it, and if she can do it, why shouldn't I? And so this is an anecdote, but we are seeing that the message that modern antiretroviral therapy is safer than you thought is out in the communities, and it's being driven by PrEP users who are HIV uninfected, and they're using these medications, and they're doing it safely. ARVs are no longer associated with HIV. It motivates HIV testing and earlier diagnosis. It builds broader constituencies for HIV programs. It's not always, not all reliant on people living with HIV. It distributes responsibility for prevention, which is undermining HIV stigma, undermines criminalization, and engages and empowers seronegative people, and it fosters agencies. So these are all qualitative findings from demonstration projects. And, but this is a press, a news article, which I think quoted Mark Thompson, age 46. He says, I'm an HIV positive man, and he describes how PrEP is decreasing HIV stigma. He says, I'm on treatment and I'm undetectable, and it's really unlikely that I'm going to pass HIV to my partner. But relationships can be a challenge, as HIV is a big barrier between me and the guys I date. Sometimes sex lacks intimacy, and you don't always get close to each other. There's always that fear in the back of my mind that HIV could be passed on. If we had PrEP, it would take that fear away. So this is what we're hearing from people living with HIV after they get over their initial shock that anyone not living with HIV would take these medications. Many of them discover that PrEP undermines stigma and makes us all equal in some ways. We're all human beings struggling to deal with HIV and get what we want from our social lives and our sexual lives. And so PrEP has been an equalizer in some sense, and it's undermining stigma. But this is the big benefit that we're seeing, is that PrEP is allowing sex without fear. And Cal Strode, a young man, was quoted as saying, PrEP would allow me to have sex without fear for the first time in my life. It would remove the month-long hangover of psychological anguish after sex, worrying about whether or not I might have put myself at risk for HIV and looking for the slightest sign. And then he goes on to say the entire gay community is affected by this kind of anguish, and it only fuels the epidemic because when people feel anxious, they don't talk about it. So this is actually, it caused me to revisit the literature on risk compensation, which in the HIV community, I think we've learned a little bit from that experience, which derives mainly from driving safety. And the concern is that if you lower your perception of risk, if you take the fear away, that people will just drive faster and more recklessly, and you'll end up with the same number of accidents. But in fact, that wasn't in the end, the conclusion that the pioneers of risk compensation theory came to. And I quote one of the pioneers, Gerald Wild, who wrote in Safety Science many years ago that in fact, belief in future value is what fosters safer driving behavior, and the perception of risk only has short-term effects on driving behavior. It can increase or decrease behavior, but only in the short term. Long term, it's belief in the value of the future. And it caused me to speculate, what are the benefits of PrEP, and how is it fostering a belief in a more valuable future? And in fact, it is allowing people to plan to stay free of HIV. It's allowing them to plan for their sexual goals, and they're having more control over their risk, and they have pleasure. And these are all factors that were found in driving safety studies to be associated with safer driving. Not planning for sex, actually, but but control over sex, control over risk and pleasure were key factors. Now, the problem, I think the current challenge is making sure that everyone benefits. And this is, again, San Francisco data showing the case rates of new HIV diagnoses. And you can see they're dropping, but it's mainly among white MSM. The case rates have been more stable among Latino and Black MSM. So there's unequal progress. And I think there's some, and this is the biggest opportunity, I think, for research and for advocacy, is how to adapt prevention programs in general, and PrEP in particular, for diverse groups of people. And I think we need to focus on people of color, young adults, trans men and women, people who use drugs, cisgendered women, and transgender women, and making PrEP easy. And so there is some activity going on in each of these areas, but it's not really enough. And there's so much that we can learn about how to offer prevention in general and how to offer PrEP in particular that I would encourage any of you who have interest in this field to jump in, because there's so much to do. And I wanted to highlight young people. Incidence typically is higher in young people around the world, and young people are not as adherent to PrEP, although some do use PrEP. This is a bar chart from the Adolescent Trials Network 110 study looking at young adults, MSM, between ages 18 and 24. And the green part of these bars is the group of men who are doing fine. They're using PrEP, they're achieving drug levels that are associated with nearly complete protection from acquiring HIV. But their proportion reduces over time, and it's only maybe 30-40% at the end of the year who are still nearly completely protected. Now the yellow part of this there's substantial protection associated with that level of PrEP use, maybe an 80% reduction in risk. That's nothing to quibble about. It's a substantial benefit, but you can see that there's a substantial portion of young people who are not using PrEP effectively. And so this is a problem that needs to be addressed and solved. I think one of the pioneering centers that I'm aware of is called Philadelphia Fight. It's at Penn, and they have a cohort of very young people between the ages of 16 and 30. And one of the secrets to their success in their PrEP program is wraparound services. But this is not just your usual FQHC wraparound. This is wraparound services on steroids. I mean, they provide showers and food and trauma therapy and clothing and laundry, sexual health care, one-on-one support, info, referral, all of this, really. And in particular, I think it's critical that they create a social environment that's attractive, that's non-traumatizing, that's friendly, that's where people can meet their friends, meet new friends. This is one of the lessons we learned from our trials. Our most successful trial sites for recruiting young people were ones that made their waiting rooms into a social event. And I think you can see here that Philadelphia Fight has done this as well. So, but this is just one anecdote. I think that in every community there's another series of ways to get prevention out to young people, and we need to break the mold and engage with youth leadership to really make this happen. Now, what about injectable PrEP? This is the late Jeff McConnell showing us where injectable PrEP is injected. And we just completed the ECLAIR study, so I wanted to show you some of that data that was presented by Marty Markowitz at the retrovirus meeting. And the study is called ECLAIR, and it was a phase 2A safety study of a long-acting injectable PrEP in HIV uninfected men. And there was an oral lead-in phase followed by an injectable phase. There was a placebo control. That was made possible because people were actually low risk in this study. This was not a group of high risk men, it was lower risk men who wouldn't otherwise be on PrEP. And then there was a long follow-up. They received a total of 3 injections. And you can see that there were very few serious side effects, and they were evenly distributed between the placebo and the active arm. But the injection does cause some soreness. And 59% reported injection site pain that was graded as grade 2 or 4. Typically it lasts a few days, and it is most often mild, but it can be moderate in severity. But importantly, when asked whether they would like to go back to taking a pill or continue to take the injection, the majority, 60 to 70%, said they'd rather have the injection because they liked the convenience and they didn't mind that their butt was sore for a day or two. Now, the last comment I would like to make is, what about on-demand PrEP dosing? The FDA, so I'm going maybe off-label a bit here. The FDA's label says that PrEP should be taken daily, and that's the CDC recommendation as well. But the European AIDS Clinical Society recommends on-demand dosing as an alternative dosing strategy. So if you're in California, you have to take it once a day, but if you're in France, you can take it before and after sex. Same pill, different recommendations based on different data. And the data was a very powerful iprogay study that reported late last year. And their strategy was to have men who have sex with men take 2 tablets 2 to 24 hours before sex, and then 1 tablet 24 hours after sex, and then a 4th tablet 48 hours after sex. If they were having sex every day, they would end up on a daily regimen, but if they were having sex infrequently, they could dose strategically in this particular way. The goal was to decrease the total number of tablets taken, as well as they hoped it would reduce side effects. And then finally, they also wanted to build in a way to start and stop PrEP. And actually, I failed to really talk about this. This is data that we have from iPrex, in which we've divided the quarters among HIV seroconverters according to whether they reported high-risk anal sex or condomless anal sex. And you can see when that they started PrEP, the majority had reported condomless anal sex, and that in fact was motivating their interest in participating in PrEP. Mind you, every single one of the people, every row here represents a different seroconverter. And every single one of these individuals eventually became HIV positive, and so they were indeed at risk for HIV. But their risk was not evenly or universally distributed across time. You can see that the majority of people move in and out of seasons of risk. And now we realize it's moments of risk. There's risky moments, and so people have periods of risk that they may not recognize as such, but it's not constant over time for the majority of people. The majority of people who seroconverted in our trials were not at risk every quarter. And much of the non-adherence that we saw was among people who were not having any sex at all. I mean, imagine participating in a trial and you're taking a pill every day to prevent HIV, and you can't remember the last time you had sex with anyone. You get to a point where you feel like you can stop. And so the IPREGAY study wanted to build in a recommendation into the regimen that allowed people to know when they're supposed to start PrEP and when they're supposed to stop it. And it's about sex. It's all about sex. So if you're going to have sex, you take PrEP, and then if you've had sex, you take it for 2 days after, and then you stop. Did it work? It did. There was an 86% reduction in HIV acquisition. Over time, the 2 seroconverters in the active arm, in fact, had stopped PrEP months before they seroconverted. So they weren't on the recommended regimen at the time they seroconverted. So the number needed to treat using this strategy was 18. So it worked. It was highly effective, at least in this group of young men. Now, we were interested with my colleagues at the HPTN about whether daily and non-daily PrEP regimens were more or less feasible relative one to the other. And so we randomized women and gay men and transgender women to either receive a recommendation for daily PrEP or before and after sex, it was randomization either to daily PrEP or PrEP before and after sex, or PrEP twice a week with a post-sex boost. So there was a 3-way randomization. And we followed them with weekly interviews, drug concentration measurements, and then we had a cute little device here that sent a text message to our server every time they opened their medicine bottle to take a dose. So we measured adherence using state-of-the-art ways. We conducted the trial in women in South Africa and gay and men and trans women in Harlem and Bangkok. And this is data from Bangkok, our most successful study site, that showed that when you looked at who was able to take tablets before and after sex in the 3 arms, that the coverage of sex acts with PrEP use was roughly comparable between the 3 arms, daily, time-driven, and event-driven. It was a little less for event-driven for sure, and the event-driven is just pre and post-sex. The time-driven was 2 tablets a week, regardless of your sexual activity, and then a post-sex boost. But all 3 recommendations did relatively well. Interestingly, the hardest dose to take in this group was the post-sex dose. And that is consistent with our experience with post-exposure prophylaxis, which is in the post-coital state, it can be hard to think through calculations of HIV acquisition risk. And we see this in this study, that the challenge of even thinking about HIV after sex is high. But the point I'm making is that the non-daily arm did relatively well in Bangkok, less well in Harlem, and less well in among women in Cape Town. We thought that less frequent dosing would decrease side effects. It really didn't. We saw here, this slide actually shows the proportion of people who had protective drug levels in the blood. And you can see that all 3 arms had a substantial proportion of the study cohort that achieved protective levels of PrEP. And then this is a slide about side effects. So we took a new approach to assessing side effects. In the past, in our prior trials, we just asked people an open-ended question at every visit. We said, how are you doing? How are you feeling? Anything happening? And in this study, we asked them specific questions about side effects. And we do see there is a startup syndrome associated with Truvada use, and it occurs in about 1/3, up to 40% of people. Okay, so I wanted to end with this notion that, that the dissemination of innovation is never complete. We should actually be happy if we can get 60% of the people that we wish to do something to actually do it. And when we think of HIV exposure as the target, if you will, condoms covered a substantial amount of that exposure, especially in the 80s. It's receding over time. Treatment covers another substantial portion of it, but it leaves a large number of people who are not engaged in therapy in a sustained way. And it's really the combination of all 3 that allows us, and the combination of all 3 and accepting that no single intervention is going to be picked up by more than, say, 60% of your hope. But all 3 together, offering all 3, allows everyone to find at least one way, sometimes 2 ways, to protect themselves from HIV, and this is the way the epidemic ends. So in conclusion, PrEP demand in the US reached a tipping point. PrEP users as champions stood up to stigma. I think that was the key issue. Diverse PrEP providers have emerged. PrEP use scaled up massively in San Francisco, and we are seeing a decline in diagnoses. Behavioral safety appears to be driven by belief in the future, and PrEP can have a favorable role in fostering belief in positive outcomes for the future. And finally, long-acting injectables and strategic dosing may be options for the future, but we have something that works today, and one challenge for us is how best to use it. And I always end by thanking or mentioning that PrEP was made possible by mostly young study participants who believed that research could improve their lives. And the goal of this phase of my career is to make good on this promise. So thank you very much.
I think we could take perhaps 1 or 2 questions if there are any from the audience.
Thank you for that great presentation. On the HPTN 067, what do you mean by the coverage slide? It wasn't clear to me what you meant by coverage.
So we define coverage as having taken a tablet before sex and after sex.
The uptake in the vaginal compartment being so much longer than the anal compartment, is there ever any evidence that event-driven PrEP is going to work in the vaginal compartment?
The only evidence is for MSM, and you're right. It takes more doses per week to achieve protective concentrations of drug in the vagina. For men, we see very high levels of protection associated with 4 or more tablets per week. For women, it takes 6 to 7 tablets per week to achieve that. So, but I think that for all PrEP users, we need to give them advice about how to start and how to stop. On-demand dosing, I could see working for rectal exposure for anyone who's rectally exposed. But for vaginal exposure, I think we need to come up with another plan for counseling around how to start and how to stop.
The finding on that you showed us from the ATN, the Adolescent Treatment Network, and youth, by the end of the 48 weeks, about half the kids were not covered effectively. That's a common finding.
Yeah.
It's in the vaginal ring studies and lots of different studies. It's the young folks who are more difficult. Are there any special efforts now trying to understand that better and maybe intervene differently?
So yes, I think that there's actually a nice blog written by Shannon Weber in the Huffington Post, and she collaborated with a number of young people and people who do this line of work. And they came up with 4 promising strategies, but one of them was youth leadership, involving youth in your program delivery and in designing your program, not just well, they should be employed as staff, but they should also be helping you design your waiting room and setting up your programs. That was one of the key elements. The other is flexibility. I work with the Crush Project in Oakland, and they're disappointed that many of the young people do not make their scheduled visits. But in fact, they've set it up nicely so that you can walk in and get PrEP without an appointment, and then you're expected to make your appointments going forward. And but there's really allowing walk-in follow-up for PrEP is a promising strategy. So building in flexibility, sort of leaving the judgment at the door is also key. But I also think that we need to be sympathetic with the older providers in the room. Because in fact, it is. No, I think that one thing I say is that young people actually intend to do what older people like myself most fear. Their intention is to inherit the earth, and they're going to do it. And so, I think that our healthcare providers are often afraid of youthful sexuality, and let's just accept that it's a scary thing, and that that should not drive our clinical practice, but it is scary, and so we should take care of ourselves in that regard. Yeah.
Congratulations on the magnet. I mean, it has inspired me for many years, and it continues to inspire me. We have, in the last few months, made a real effort to also deliver same-day PrEP services.
Yeah.
What we found was that there was a significant number of people who called for PrEP who actually needed PEP. And then, we had this unique opportunity to kind of strike while the iron is hot. And so we really try to get people to leave with PrEP in hand. So that's easy. We can do that if they have health coverage. But for the people who don't have health coverage, do you have some way that you're able to make that happen more expeditiously? We can do the Gilead paperwork, but it takes a little while to get that approved. Do you have starter kits? We've talked to the public health department, we've talked to Gilead about a starter kit, some way that we can actually ensure that people leave with PrEP in hand.
Starter kits is certainly an option, although it is known that giving people a month's supply is better than giving them a starter kit and asking them to follow up. You do lose some people along that road, but a starter kit is better than nothing. I think you'll find that if you have a basis for providing PEP, you can get that regardless of insurance status. PEP is a medical emergency. It's accepted as such. The industry vouchers for PEP typically will provide a month's supply regardless of insurance status. And the voucher is faxed directly to the pharmacy, and it can happen. We're finding it's easier to provide PEP than it is to provide PrEP, because there's no sensible risk manager anywhere who's going to say, no, even though PEP's indicated, we're not going to provide it because you haven't filled out the form, because they know the consequences are severe. So yeah, I think you're going to find that PEP can be mobilized. Then it comes down to your medical history. I mean, in order to provide PEP under CDC guidance, there has to be an exposure in the last 72 hours. Are you always 100% certain of that sexual history, and what kinds of flexibility do you have in that regard?
So Bob had a 2:15 plane flight.
Oh, but I can take one more question.
All right, one more question. And he has to go down the 405 yelling.
Yeah,
so.
really.
Hi, I'm Sonali from the LA County Health Department. So
Hi.
I just wanted to say that we actually have estimated the number of people in LA County
Yeah.
who are eligible for PrEP, and it's around 58,000.
58,000?
Which is actually very similar to the number of people living with HIV-6, another data point for you.
Yeah.
Great.
But I was just wondering if you could comment on rising STD rates. I mean, we certainly get that question a lot, and we are seeing really tremendous rise in STDs. And there's one thing to be said about getting people tested and treated, and that's what PrEP can enable us to do. But we're seeing a trickling over to our female population in LA County, more congenital syphilis cases. And so sort of like, because there's just a bigger reservoir of people with syphilis around, it's starting to trickle into women, which it was kind of siloed for a long time. So I just wondered if you could comment on that.
So I don't think gonorrhea in women can be laid at the door of gay men. The STD rates have been rising since 1996, and they haven't been used as a reason not to provide HIV treatment. And I think arguably they shouldn't be used as a reason not to provide PrEP. PrEP does provide an opportunity for testing. It also can potentially, there's no guarantee about this, but we are hearing that it's changing the conversation that happens in bars. The old conversation used to be all about HIV status. When was your last test? Are you on therapy? Is the therapy suppressive? Now, people are being asked, well, when was your last syphilis test? And did you tell your partners about your positive syphilis test? Did you get it treated? And, I'm not worried about HIV because I'm on PrEP, and I know how much of my PrEP tablets I'm taking, but I do not want to get syphilis from you because the shot hurts, and I don't want to tell everyone that I've had sex with that now I have syphilis. And I don't want the Department of Public Health to be getting that information either. So folks do sometimes transition to being curious and focused on STDs. So my advice to you is that if controlling STDs is the goal, let's focus on that and not controlling STDs as a way to indirectly affect HIV rates, which is the old discourse. The new discourse can be syphilis is something to avoid. Let's avoid it with directly targeted syphilis programs. And those look very different from syphilis programs that are riding piggyback on HIV programs. They look different because there's more testing, there's less reliance on HIV risk to identify people at sexual risk. But yeah, STD rates have been going up since 1996. It's not due to PrEP. There's not enough PrEP to really explain it. And syphilis in women certainly is hard to explain based on PrEP or HIV treatment. I think it's that heterosexuals have sex too, and it's sometimes risky. So, thank you.